Today I will talk on acromioclavicular joint injuries. Anatomy and biomechanics. AC joint is a diarthrodial joint. AP stability is maintained by acromioclavicular ligaments. Superior inferior stability by trapezoid and conoid coracoclavicular ligaments. Trapezoid ligament is located an average of 25.4 mm in males and 22.9 mm in females from the lateral end of the clavicles, almost 2.5 cm from the lateral end of the clavicle. The conoid ligament insertion is located medially and an average of 47.2 mm in men and 42.8 mm in females from the lateral edge of the clavicle. Conoid is responsible for about 60% of the restraint to anterior and superior clavicular displacement and rotation. That is the main stabilizer of the lateral end of the clavicle. Mechanism of injury. Acromioclavicular joint, AC joint, separation is usually the result of a fall into the lateral aspect of the shoulder and frequently occurs during sports activities. Classification parallels the pathoanatomy and serves as the basis for the management decisions. Classification. Popular classification is Rockwood classification for AC joint injuries. They classify into from 1 to 6. One is there is a AC ligament sprain, coracoclavicular ligaments will be intact, deltopectoral fascia normal, coracoclavicular interspace distance normal, and X-ray will be normal. Type 2 AC ligaments disrupted, coracoclavicular ligaments sprained, deltopectoral fascia normal, coracoclavicular interspace distance is less than 25%, and in X-ray there will be widening of the AC joint. Type 3 AC ligaments disrupted, coracoclavicular ligament is disrupted, deltopectoral fascia disrupted, coracoclavicular interspace distance is 25 to 100%, and in X-ray you can see widening. Type 4 all two ligaments fascia damaged, the distance increased, and X-ray will show clavicle posteriorly displaced. Type 5 all the two ligaments and the fascia disrupted, and the coracoclavicular interspace is 100 to 300%, and in type 6 AC ligament, both the ligaments are disrupted, fascia also damaged, coracoclavicular interspace distance is decreased. In type 6 it is decreased, clavicle displaced inferior to coracoid. Treatment of less severe injuries type 1 and type 2 is non-operative and straightforward with a minimal long-term sequelae. More severe injuries type 3 to type 6 are characterized by increasing disruption of the stabilizing structures, that is acromioclavicular and coracoclavicular ligaments as well as deltopectoral fascia. 18.2% type 3 to type 6 injuries had a concomitant intra-articular shoulder pathology, and you have to do an MRI scan in such cases to rule out intra-articular pathology, and you have to treat depending upon the findings. You have to take a true antero-posterior standing radiograph of the acromioclavicular joint bilaterally with the X-ray beam directed with a 10 to 15 degrees cephalic tilt and with the use of 50% of the exposure, that is usually making a standard radiograph of the normal shoulder, comparing the injured right AC joint with the normal AC joint. MRI is helpful in identifying potential associated injuries. Already I told you, more than 18% of the patients from type 3 to type 6 will have associated shoulder injuries, associated intra-articular pathology. Treatment of AC joint injuries. Type 1 and type 2 are treated with a conservative method, sling immobilization, some pain medications, but pain of the AC joint injuries persists as long as 6 months after injury. You have to convince the patients, and in some patients, that means almost 33%, one-third of the patients, pain persists for up to almost 6 years. The counseling of the patient is very important. The management type 3 injuries remains a controversial and is individualized. While a return to previous level of functional activity with a non-surgical treatment has been documented in a number of case series, surgical reduction and coracoclavicular ligament reconstruction has been associated with a favorable outcome and can be considered in patients who have high functional demands on their shoulders or in athletes who participate in overhead sports. And majority of patients or not don't come into these categories, you can manage with a non-surgical management. Although it is generally agreed that the acute type 4 to 6 injury should be treated surgically. Type 4 to 6 non-surgical treatment has been unsuccessful. Not one technique has been shown to be clinically superior to another. Surgical repair of acute type 4 to 6 injuries can be carried out with a number of techniques, including direct AC and CC ligament repair, coracoclavicular ligament transfer, tendon graft reconstruction of the CC ligaments or clavicular hook plates. Anatomical coracoclavicular fixation has improved initial biomechanical properties. Not a one technique has been shown to be clinically superior to another. The surgeon has to choose the least convenient technique for each patient. Complications and residual pain can be attributed to the implants and progression of arthritis. Some loss of production over time in operated patients is common. Type 4 to type 6 injuries should be reduced anatomically and accurately. Direct repair is better and supplement or protect the ligaments, repair the deltoid and trapezial fascia, and exercise the lateral end of the clavicle in case of AC joint arthritis. Late treatment of chronic AC joint injuries. Late treatment of chronic AC joint injuries usually requires the tendon graft reconstruction of the coracoclavicular ligaments. Enhanced understanding of the anatomy has led to development of more anatomic positioning of the tendon grafts. Most studies report complications that are directly attributable to the surgical repair. Recent advances in arthroscopic surgery and innovations in the fixation implants have led to less invasive surgical techniques, although data so far suggest that results are no better than those with a open reconstruction or repair. There is one paper in American Journal of Sports Medicine 2013 on late treatment of chronic AC injuries. Anatomic procedures to treat disrupted CC ligaments using either cortical fixation buttons or tendon grafts resulted in an overall complication rate of 27.1%. Construct survivorship was calculated to be 86.2% at 12 months and 83% at 24 months. Good to excellent outcomes could only be reported in those patients who did not have a complication.